Hi, I'm Frank Speidel, a retired emergency physician and recovering hospital administrator, and welcome to The Doctor Is In. Again, we will discuss the COVID pandemic and its interface with society. And as always, I advise I am neither an epidemiologist, public health official, nor infectious disease specialist. Always defer for healthcare guidance to your primary physician, your local and state health departments, and the CDC. When I wrote the introduction to today's show, we had lost 636,000 Americans to the pandemic. You'll see a slide with showing mortality rates by nation and state. As you know from prior shows with Dr. Monica Gandhi of UCSF, CDC Director Dr. Rochelle Walensky announced yet another CDC reversal in masking, now recommending that fully vaccinated adults resume masking indoors. In making this recommendation, Dr. Walensky stated, in rare occasions, some vaccinated people infected with the Delta variant after vaccination may be contagious and pass the virus to others. In rare occasions, may be contagious. So much for expecting extraordinary actions to be based on extraordinary evidence. This is extraordinary evidence. In response to pressure to produce the evidence for driving this change, the CDC cited the August 7th Morbidity and Mortality Weekly Report released early on 30 July. This posting deserves comment. There is traditionally a hierarchy of medical literature reporting. The lowest in the hierarchy is the consensus of experts. The highest quality evidence is double-blind controlled randomized trials study where neither the subject nor the experimenter know whether the intervention is real or a placebo. In between are observational studies of various sophistication. The sun rose and the temperature rose, or the sun rose and my dog died. Possibly slightly better than the consensus of experts and not quite as powerful as the double-blind randomized control study are randomized control trials. Here, the participants are randomized into similar groups and subject to an intervention, and then after the intervention, the results are observed. The study cited to justify the recommendation to remask fully vaccinated adults indoors is an observational study. Quote, during July 2021, 469 cases of COVID-19 associated with multiple summer events and large public gatherings in a town in Barnstable County, Massachusetts. Of the 469 cases, 74% occurred in fully vaccinated adults. And, quote, patients with COVID-19 reported attending densely packed indoor and outdoor events at the venues that included bars, restaurants, guest houses, and rental houses. The MMWR report went on to report the RT-PCR TC values were similar. The TC values were similar between the vaccinated and the unvaccinated, adding CT values obtained with SARS-CoV-2 qualitative RT-PCR diagnostics tests provide a crude correlation with the amount of virus present in a sample, and also can be affected by other factors other than the viral load. Although the assay used in this investigation was not validated to provide quantitative results, end of quotes, the entire report has more qualifying words than there are sprinkles at a 5-year-old's birthday party. Actionable content is virtually non-existent. Absent from any lay press release covering this release are the deluge of qualifying words, equally unreported by the conventional press from this outbreak, that there were only 5 hospitalizations and no deaths. Equally absent from reporting are comments of the Association of American Public Health Laboratories, where APHL states explicitly CT values cannot be used to infer infectiousness. And, oh, by the way, this report, 87% of the subjects were male. It's hardly a representative sample, as most of the United States is not 87% now. So we are making public policy. We are making public health policy on observational, non-peer-reviewed rush studies of a non-representative sample planted thick with mites, could be's, might be's, and drawing conclusion using a lab value in a way expressly prohibited by the Association of Public Health Laboratories. However, be of good cheer, though. The CDC did report an RCT study in May of 2020. You'll see it up on a screenshot here. And the result about masking isn't consistent what they've been saying, but hey, that was an RCT study. Who likes randomized control trials? Driving discussions and questions. I have invited to former federal prosecutor and state prosecutor, nationally published author, Mr. George Parry, to question my conclusions and question my confusion and drive me into clarity. George, help me out. Perhaps in answering your questions, I can clarify my thoughts. And Mr. Parry, welcome to the Doctor's Inn, and thank you for your service.
Well, thank you so much. It's a privilege to be here with you. I want to say, first of all, I'm a big fan of your work, a big fan of your show. I consider it the highest and best use of public access television. And frankly, I wish you were on nationally, and maybe that'll come. But, you know, your remarks, from my limited knowledge, are spot on. I can only look at this as a civilian. I don't have a medical degree. I'm not a doctor. I don't play one on television. So, but I know how to read, write, and speak the English language. And
quite well, I might add.
Oh, well, thank you. But let's go back to what I have always considered to be a key question, which is the efficacy and usefulness of polymerase chain reaction tests to determine the spread of COVID, that is, who has COVID and who doesn't have COVID. And built into that question would also be, where you talk about COVID death certificates, can you offer us any guidance as to who's dying with COVID as opposed to people who are dying of COVID? How do those stats break down? But beginning with the PCR test, do you think that's a proper way to test for this disease?
I think it is. It would be my preferred way to decide if somebody has the SARS-CoV-2 virus present in their nasopharyngeal area. Infectivity is a whole bunch of other things. It depends on the viral load. It depends on the situation in which people have it. I feel reasonably comfortable that the PCR that looks for part of the genome is a measure of whether somebody has part of the genome, part of the SARS-CoV-2 virus present on them. That is not the same thing as whether they're infectious. It seems a reasonable inference that they might be infectious. The challenge is that we can find it on surfaces, and that does not mean the surface will infect you. There's been a lot of confusion about fomites, such as this, being a vector to transmit. To my knowledge, I always ask my real scientific guests, can you show me a report where there was a fomite transmission, although I might might be able to test and find, with the PCR reaction, find evidence of the SARS-CoV-2 virus. I believe that the transmission, George, is aerosol, and there's some droplet transmission. But for the most part, I think the consensus is that it's an aerosol transmission.
Well, picking up on that point, with the aerosol transmission, what about the usefulness of masks to begin with? Let's talk about masks, and then we'll get into social distancing and lockdowns. But just talking about masks right now, I have heard it said that the kinds of masks, and I brought a prop today, so here, this is viewers, a mask, the one I use, and I've heard it said by knowledgeable people that wearing one of these masks is comparable to wearing a chicken wire raincoat in a thunderstorm to stay dry, that this mask is not going to be effective in preventing you inhaling this aerosol, this airborne virus. Is that correct, or
That seems consistent with my experiences and of reading, of trying to read and understand the literature. I think it is an aerosol transmission. There was controversy. The CDC was originally, they waited till like July of 2020 and they put it out that it was aerosol transmission was present, and then they took it back. And back in 1994, the CDC was involved with a bit of a controversy that the evidence then showed that tuberculosis could be transmitted by aerosol. And at that time, the CDC was pushing for N95 masks to be used by healthcare providers providing care for people suffering from multi-drug resistant TB. So I think back in the 90s, there was a sense in the CDC that the N95 mask would be the standard of care for aerosol transmissions. Now, as Dr. Gandhi and I were laughing on my last show, if you've ever worn correctly an N95 mask, it's going to leave marks on your face, and it increases the work of breathing. I had a lived experience with basically a kind of N95 environment. When I was going through my Navy training, they educate you about the use of protective gear for chem warfare, which includes this nasty Star Wars kind of rubberized mask that you have to apply properly, tightly. So you put it on properly. They put you in a tent, and they discharge some irritant agents like a tear gas, and you learn that you can breathe comfortably, or at least breathe, or at least not be irritated when you're inside this tightly applied mask, like an N95 mask. And then they make you take the mask off, and boy, the world changes for you. You want to get out of that tent really quick. So we may feel good, but I agree with you. I think if you want the protection that people expect from masks, it's going to be an N95, properly fitted and worn, and that is not a sustainable, comfortable experience.
Well, I know that at least one expert that I respect, Michael Osterholm from the University of Minnesota Medical School, has said that if you're wearing one of these masks and you can still smell, say, cigarette smoke, that means that if cigarette smoke can penetrate the mask, then this virus can penetrate the mask. So is this just theater that we're being told about, or is...
I would, it's a feel-good, for me, it's a feel-good thing. Am I right? I don't know. I can pull articles that argue that this makes a difference. And
Okay.
the randomized control trial that the CDC has, I think it's May of 2020, was a well-done study. It was out of Hong Kong. It was done in May 2020, and they used not COVID, not the SARS-CoV-2 virus, they used an influenza virus because they wanted a large N, a large sample size, and they had lots of good solid data. This is the group out of Hong Kong who's done a lot of really fine work. And they indicated that it's not fomite transmission, all the deep cleaning doesn't make a difference, and that these masks really don't make a big difference. If you were looking at things to change things indoors, we've done this in hospitals forever. It's called air exchanges. The air exchange, I think, is more important than the mask. Now, when was the last time anyone saw anything from the CDC about in schools we need to really amp up the air exchanges?
Yeah.
That's what we do. When we have rooms in a hospital, there will be rooms or suites where we do some procedures that we're going to aerosolize infectious material. The CDC has well-published and well-documented air exchanges to keep everybody healthy and happy while they're doing these somewhat risky procedures. And I have yet to see any big push for looking at air exchanges by the CDC in schools.
Well, now they're talking about as children go back to schools, that the CDC is saying that they should be wearing masks. You have said in the past that there is a trade-off in any one of these procedures. Let's talk about in the context of wearing masks. What are we trading there for the perceived security or enhancement of the children's safety by making small children wear masks in class?
Again, Monica Gandhi, who's one of these young giants coming up, has written extensively about the harm that we are doing to children with masking and with doing virtual schooling. Now, I hope that virtual schooling as a solution to containing a virus that can't be contained is in the past. Now, one of the sad things, George, people who have to make these decisions have a really difficult situation. Whether you mandate masks or not, some child at some point in time, a young child, will get COVID-19. And if enough children get COVID-19, they may not get it in school. They may not get it whether they were masked or not, or whether their teachers were vaccinated. They will get it. And a finite number a very diminishingly small number will go on to develop multi-system inflammatory syndrome in children, MISC syndrome. And that's a very devastating, profoundly terrible illness. That's life. We can't make it perfect all the time. Everyone that we can save with reasonable measures, we're going to do. But the measures are going to require trade-offs. We could save 24,000 people a year in the United States if we eliminated cars and trucks and we all went back to riding horses. We would lose a few hundred from being thrown by horses. There are risk-reward trade-offs. We do this all the time in public health.
All right. Well, let's talk now about vaccines and the risk and the rewards of having vaccines. And for this part of it, if we could talk about vaccinating children. I know that there have been documented cases of myocarditis among children who have received at least one of the vaccines. I believe it's the Pfizer vaccine. But Moderna, Pfizer, they're both mRNA vaccines. What is your evaluation of that in terms of risk and reward in terms of vaccinating children?
Well, right now I don't think there's a vaccine approved for children under 12, but I think for older children, which would be 12 and above, I advocate vaccinating them. I think that we live in a time where you will either be vaccinated or you will naturally acquire COVID-19. Mm-hmm. There are episodes of everything we do has a consequence. I think, and I can't recite the study off the top of my head, that more children will get myocarditis from having COVID-19 than will get subsequent to the immunization. Do we know everything 100% for sure? I don't know anything for sure. I'm not even sure momentum is always conserved. I think it is. But what we know for sure is subject to doubt. And at this point in time, I would recommend to my friends, I've done it, that if they have a child 12 and above, if they don't have any contraindications, to get it. That does not mean that one of these children may not subsequently have some sequelae to it. But of all the vaccines I have seen in my career, I am very confident that the mRNA vaccine is a wickedly intelligent concept that I enthusiastically endorse. One of the heroes, not well known, is a man named Dr. Drew Weissman down at Penn, who was doing this research long before. He's been doing it for 10 years. And the concept is kind of a beautiful thing. Instead of giving you the agent in a modified or truncated form that prevents severe illness, instead of giving you the agent, what it does is it gives you a manufactured messenger RNA. That's a little set of instructions that we take into our body, we get it injected, and our cell absorbs it and then makes the spike protein, which is the infection driver. It doesn't make the virus. It makes the glycoprotein that is the driving effect of it's the way the virus attacks our cells. And in doing that, our body makes antibodies to that, and without ever having been exposed to the virus itself. The numbers are large. It's been well watched. With the intensity with which we're looking at this pandemic, if something really bad was happening with the mRNA vaccine, we'd know it. And again, it's always a challenge. The post-hoc propter, the observations have a huge challenge. The sun came up and my dog died. Mm-hmm. There is a temporal relationship, which may not be a causal relationship. Do I know this for sure? No, but that's what I'm recommending because we do have to make decisions.
What about the effectiveness of the vaccines in regard to these contagious variants that they're talking about now?
Boy, I believe that there are the same order of effectiveness for the variants as what I've seen so far, what I've read. It looks to be the same order of efficacy, this is one of the more effective vaccines that I've seen reported. Our influenza vaccine, my good Lord, in a good year we get 60% effectiveness with it. One year we had an effectiveness of 29%. So we're up in the 90s. And the key is, it doesn't mean you won't get the virus. You will get the virus, but you won't become seriously ill from it. And it's I believe it's going to help from you transmitting the virus.
Okay. Well, in terms of the hospitalizations, they're talking about increased hospitalizations now with the onset of the Delta variant. In the beginning, when they were treating people in the hospital at the beginning of this pandemic, they were using ventilators. And as I understand it, we learned through bitter experience that using ventilators was not necessarily a good idea, that they were actually causing more harm than good. But what about with the Delta variant now? We have increased hospitalizations. Do we have better therapeutics now for treating?
Boy, that's a good question. I think that's one of the giant things that has happened during the pandemic. We rediscovered something that in treating people with respiratory failure, COVID kills people with respiratory failure. It makes it impossible for us to do the exchange of oxygen that when we ventilate, when we breathe in and out. We reminded ourselves of an old concept that a little bit of acceptable low oxygenation is okay, and we want to try to avoid ventilating people with high pressures. That happened about 20 years ago. A good literature came out. We used to ventilate at about 10 to 15 centimeters per kilogram when we'd set the ventilator. It's down to about 6 to 8, and we recognize now that we don't want to ventilate. We want to do positional optimization of the person's ability to move air in and out. We may end up using a ventilator, but we're going to be very cautious about it, because the pressure of an already injured lung being forcibly expanded is a challenge for the body.
When you talk about positional, do you mean putting them on their stomachs?
Yes,
okay.
Different. Yes, exactly. It is very. There's a thing called positional hypoxia. If I strap somebody in a chair and put them upside down with a little bit of flexion anterior, it's very hard for the diaphragm to move up and down, and for people to move air in and out. So.
Okay. All right. Well, we've heard a lot of talk about herd immunity. And in terms of herd immunity, first of all, what is that, and how does that immunity compare to the immunity conferred by the vaccines?
Herd immunity is indifferent as to whether you've naturally acquired the disease or whether you've been vaccinated. It means that the agent, the infectious agent, will not be able to leap from person to person. For a highly transmissible infectious agent like measles, you have to have herd has to be about 95% immune to it, and it looks like the variant may have not quite that high, but you're going to need up and around the 90% of the population to have some kind of immunity, either acquired naturally or by vaccination.
Should people who have had COVID, should they receive the vaccine?
That's a question that's above my pay grade, and okay. I'm reading the literature right now. One of the things out of this time and this is what we know for certain is really changing and very shaky. There's a few things I have a good sense that the vaccines work, and I recommend it to my people that I still talk to and give advice to. I recommend that. So I feel good about that. But there's so many other things that we just don't know for sure. And one of the scary things is large changes that hurt society, that interrupt us, that harm children's development, that harm children's security, that may be necessary. but we ought to have really sure evidence that what we're doing, what we're recommending, has the effect we intended to, and that we are aware of unfortunately, the concurrent effects that may not be desirable.
Let's shift gears for a second. You're talking about public policy. I've heard that you're running for coroner in Chester County. And this seems to be a radical departure from your previous professional experience and some might say your grand personal integrity. What possessed you to get involved in politics and to run for coroner of Chester County?
An article by Marie McGinnis in the Philadelphia Inquirer is the start of me becoming involved in politics. In October of 2020, Marie McGinnis and another reporter from the Inquirer reported on a mishap in Chester County, where Chester County bought $20 million worth of an antibody test back in March, very proudly announcing they were leading the state in this. Just one problem, the antibody test did not work. It produced results, but the results weren't certain, and people were advised of the results. There was a woman, Renee Cassidy, Dr. Cassidy, was against using the test. According to the article, the Inquirer article said she did not think it was a good thing to do. And once the test was found to have suspicious results, Dr. Cassidy advocated for notifying people, patients that were tested and had suspicious results. And reportedly, according to the Inquirer, the county health department and the Chester County's government thought that in the time of pandemic, we don't want to make people suspicious of the health department or the county, so we're not going to notify patients. It wasn't until after the article came out in the Inquirer did they notify, with very carefully phrased language, that the test may not be correct. For some reason, Dr. Cassidy, as of July 2020, was no longer with the health department, and there's no physician voice, save for the coroner, who is not running again in Chester County. The candidate who will replace her is not a physician. In the time of a pandemic, I was asked to run because I have written an op-ed about the need to be transparent with patients locally, and I was asked by people to run just to put a physician voice in government. And George, next time I do something that stupid, would you be a buddy and tell me, Frank, what are you doing this for?
Well, I think this is an excellent development, though, because to have a professional, highly trained professional such as you serving as a coroner would be a real exception here in Pennsylvania, and I think it is really needed at this point in time.
Those are very kind words coming from a very eloquent man who's had his eyes wide open for a long time. Again, George, counselor, prosecutor, and wit, I cannot thank you enough for being my guest. And for those who are watching right now, thank you. Be safe. Listen to your local health department. Listen to your primary care physician. But questioning things, that's what makes our society work. It's what made our civilization work. Thoughtful questioning of everything is not a bad thing. It's a good thing. And censorship is not our friend. Thanks, and stay safe. An addendum to the George Parry interview. I misspoke about the authors of the investigative September 2020 Inquirer article about the Chester County antibody testing misadventure. The authors were Marie McCullough, not Marie McGinnis, and William Bender. I also owe the viewers an elaboration on the question of vaccination for those who had recovered from COVID. When I had responded, I had just finished reading a pre-pub, The Necessity of COVID-19 Vaccination in Previously Infected Individuals by Shrestha and colleagues out of the Cleveland Clinic. The study has large numbers, 49,000 subjects, and ran for 5 months and showed no difference between recovered vaccinated and the recovered unvaccinated. Since April of 2021, the CDC has recommended vaccinations of those recovered. I agree. I have only one child, my son Connor. Connor recovered from COVID, and at my suggestion, he was vaccinated. I extend to my viewers the same recommendation. If you have recovered from COVID, get vaccinated anyway. Thanks, and be safe.